So I can tell you what the global stats say. So up until about 10 years ago, America was saying screen at 50. And they noticed that in the group they were screening, they were having people live longer. So their screening was conclusively making people live longer. And we can talk about the reason for that in a while. But then they noticed that there is in their statistical studies, the age group 45 to 50 is now showing an increase in death or a higher mortality rate as a result of colorectal cancer. Now, I think it's because that curve was already shifting. But then they realized by dropping the screening age to 45, there is a survival benefit shown, and they implemented it. So now to your question, is 40 the new 45? I don't think we're quite there yet. But as we're saying, in my private practice, I think I do have a selection bias that says I'm living in a relatively affluent area and I'm new to the private practice, hypothetically in a 2-year cycle. I definitely see younger cancers. I'm seeing a lot of patients under 40, even in their 20s. So, and you would think these are all mutations that, family cancers, but they're not. I've seen quite a few that are sporadic cancers in their 40s. So if you're thinking, okay, a cancer at 40 means we should have probably screened that patient at 30. So I think the question is not should we be screening? The question is at what point does the cost-benefit balance break even?
And especially for us in South Africa that pay for our medical aids, because the medical aid still pretty much thinks of 50 definitely, but they are moving towards a 45.
I find it very easy to justify 45. I think if you've got the American population conclusively guiding saying 45, South Africa, if you're in the private sector, 45.
And let's talk risk. So we see a lot of people come through and want to know, but should I go for a colonoscopy? And then you say you are at an age where it's probably necessary, but is there or are there people earlier than 45 high risk that you want to see earlier? Is there something that makes the red light go off for some people?
So to me, the ones that I see in practice the most is the change in bowel habits. The person who's had a normal, regular bowel habit their whole life, and suddenly it's changed. Don't ignore that.
So both sides, diarrhea or constipation?
Any change. Okay. See a change.
Okay.
That's a warning flag. And it's the kind of thing that you should have investigated because it's either metabolic or it's plumbing. It's one of the two and both need to be looked at. And the last thing, and the other one is new bleeding, new blood. I mean, it's easy to blame a hemorrhoid, but that should be almost a diagnosis of exclusion, and it should be a diagnosis made by a clinician, not something you brush off, so to speak, as a hemorrhoid, because the number of disasters like that I've seen is devastating.
And a clinician that actually has done some type of examination, not just call it across the table to say it's probably a hemorrhoid. So you need to go look or feel or do some type of investigation.
Exactly. Yeah. And it, I'm quite lucky again, my drainage area, we've got a very competent GP network training to us. And it's amazing how many times I've now diagnosed the young cancers because the GP said they have hemorrhoids, but they don't look like the ones that are bleeding. And then you go and do a scope and it's a young patient and then you find something. So those are my two big flags, change in bowel habit and bleeding or blood. And then from a GP point of view or from a doctor point of view, the unexplained iron deficiency anemia. Those are the three big ones. From your own history, it's the cancer history. Is there cancer in your family? Are you a high risk? And I don't think it's a fair thing to say, do it yourself. I think see a GP or see someone who can actually go through your history and say, okay, you're at higher risk for colon cancer. And because of that, you should be going 10 years prior. So in other words, 10 years earlier than the family member's cancer.